Our next section is valvular heart disease. The most difficult thing about this is not the total amount of knowledge, it is answering questions about murmurs and auscultatory maneuvers that are extremely difficult. So this issue about presentation and one of the different maneuvers is going to be intrinsic to what we're doing. What's the best initial test and most accurate test? And you'll walk out of this section knowing the answer to every single question, and it is going to be 100% accurate, I promise. All valvular heart disease can be congenital in nature. Now, rheumatic fever most commonly leads to mitral stenosis, but rheumatic fever can lead to any form of valvular heart disease. Aging, as calcification leaves the bones and enters the valves, is the most common cause by far of aortic stenosis. And regurgitation occurs because of hypertension causing a strain on the heart. Ischemia causes a strain on that heart. And as you infarct, you regurgitate because regurgitation leads to dilation. So ultimately, anything that leads to the heart dilating will lead to leaky, regurgitant lesions. As things infarct and die, they don't become tighter and more narrow. They loosen up in the heart and become more floppy and leaky. In order to answer the question, what is the most likely diagnosis, we have to have something that's unique for each of those diseases. Since all forms of valvular heart disease can present with shortness of breath and congestive heart failure, the presence of shortness of breath enrolls in edema is never going to allow you to answer the question about the specific type of valvular lesion. You can't say that person's short of breath. They must have mitral regurgitation, because shortness of breath could be with pneumonia or mitral regurgitation or aortic stenosis or aortic regurgitation or mitral stenosis. That won't allow you to answer the diagnostic question. Only the murmurs are specific for each of those presentations. Right-sided lesions, such as the tricuspid and pulmonic valve, increase with inhalation because when you inhale, you increase venous return to the right side of the heart. And left-sided lesions, as you exhale and the diaphragm goes up, the lungs become smaller. And as the lungs become smaller, they squeeze blood into the left side of the heart. So left-sided lesions increase with exhalation because you're compressing the heart and you're compressing the lungs. But as you compress the heart and the lungs, you are still squeezing blood out of the lungs and into the left side of the heart. Right-sided lesions increase with inhalation. Left-sided lesions increase with exhalation. The best initial test for all forms of valvular heart disease is the echocardiogram. The transesophageal echo may be more sensitive and specific, but the transthoracic echo is still the best initial test. Now, there's a huge difference between the question, what is the best initial test, and what is the most accurate? What is the most accurate does not necessarily mean what I'm actually going to do. 99% of the time, valvular heart disease is diagnosed off of the echocardiogram. However, when they actually ask you, which of the following is the single most accurate test? If cardiac catheterization, now not the catheterization that puts a catheter into the coronary arteries, but cardiac catheterization where you have a catheter going into one side of the heart, into the chambers, across the valve leaflets that measure the exact valve gradient, the exact valve diameter. The best initial test is the transthoracic echo. Transesophageal echo is more accurate, but the most accurate is catheterization because the valve pressures that you might hear of on a transthoracic, how did we know how it correlates? Because we're comparing it to cardiac catheterization, to left heart cath for the left-sided lesions and right heart cath for the tricuspid and pulmonic valves. Now remember, you are not going to skip the transthoracic echo and go straight to the transesophageal echo. You're not going to skip the transthoracic. Transthoracic first, transesophageal better. Cardiac catheterization, the single most accurate. It would be great if the EKG could give you specific diagnostic criteria for valvular heart disease, but it can't. There's nothing specific with valvular heart disease. You can see hypertrophies of things. You can see a biphasic P wave in V1 and V2. Biphasic P wave indicates left atrial hypertrophy. You can see P pulmonale, a big, huge, large P wave. That indicates right atrial hypertrophy. You can see hypertrophy of the chambers. You could see an S in V1 or 2 plus an R in V5 and 6 greater than 35 millimeters. And that greater than 35 millimeters would be left ventricular hypertrophy. But the EKG correlation with chamber hypertrophy is only about 50%. And you can't confirm the diagnosis from an EKG. It's simply not good enough. So where does that leave the test? Most of the time, it leaves it as one of those things we do, but is neither the best initial nor the most accurate. Not for valvular heart disease. For ischemic heart disease, it's always first. So that means for you, on step 2CK, the EKG is one of those answers that's in the choices, but it's never right, because it's not the best initial and not the most accurate. Not for detecting the presence of valvular heart disease. In many ways, the chest x-ray is similar to this. The chest x-ray is similar to this because it may show enlargement of the chambers, but the precise anatomic correlation is simply poor, and the x-ray is neither the best initial nor the most accurate test herself. That is for the echocardiogram. Since all forms of valvular heart disease can be associated with fluid overload, all of the forms of valvular heart disease could benefit from diuretics. Now, diuretics are largely symptomatic control. All valvular heart disease can cause congestive heart failure. All valvular heart disease can cause shortness of breath. Therefore, all valvular heart disease will benefit from diuretics. Now, that doesn't mean it'll delay progression. Diuretics don't delay progression of anything in the heart. They don't delay progression of congestive failure. They don't delay progression of regurgent or stenotic lesions. But they are a therapy used simply to decrease fluid overload. But medications alone can't improve the lesions, especially not stenotics. Stenotic lesions cannot be ultimately improved in terms of the progression of the disease by meds alone. Regurgitant lesions can, but symptoms only with diuretics. Mitral stenosis is treated with balloon the mitral, because it's caused by rheumatic fever. Balloon the mitral, particularly in a pregnant woman. Balloon the mitral, because it is fibrotic tissue, but replace the aortic, because the aortic is with calcification. You can't balloon calcification. You have to replace the aortic and balloon the mitral, because you can't balloon calcium, but you balloon that fibrous tissue. The best initial therapy for regurgitant lesions is vasodilators. Now, what does a vasodilator mean to you? The best initial vasodilator for a regurgitant lesion is an ACE inhibitor or angiotensin receptor blocker, nifedipine or hydralazine. Now, if this was congestive heart failure alone from a weak muscle of the left ventricle, then ACE and ARBs are clearly superior to nifedipine and hydralazine. But for a regurgitant lesion, which simply needs vasodilation, the difference between them is pretty similar. As a matter of fact, it's so similar, you won't be asked to choose between them. Now, hydralazine has adverse effects such as lupus, such as a reflex tachycardia, such as the fact that it's difficult to take several times a day. But in terms of efficacy, they're all about the same. Now, when the valve dilates a lot, you have to replace it or repair it. Tighten it up, tighten it up. And those criteria are when the left ventricular and systolic diameter becomes too great, because you can't let it dilate it up. And how you tell if a regurgitant lesion dilates up is how empty can it get on contraction. If you can't contract that thing to being all the way empty, it's time to replace the valve. Because if the heart dilates up too much, if it dilates excessively, then you can't just replace the valves. You can't just replace the valve because how do you grab those very separate parts of the heart? You got to replace it before it dilates up too much. Well, what does too much actually mean? Well, 55 millimeters in aortic regurgitation or 40 millimeters in mitral regurgitation. That's what it means for too much. 55 for aortic and 40 for mitral. Because if the myocardium stretches too much, it won't be able to return to normal size and shape. Now, this too much thing is very difficult for a medical student. You're like, I understand what you mean by too much, but what does it mean too much? 55 millimeters of left ventricular end systolic diameter for aortic regurg and 40 millimeters for mitral regurgitation.
In terms of assessing the ventricular size, we base it on the end systolic diameter because that's a measure of how strong the heart is. If the heart is strong, you can empty the heart. If the heart is not strong, you can't empty it. How do you know how much you can empty it? At the end of systole. In other words, if you can fill but you can't empty any of it, it's not a very strong heart. We look at the ejection fraction, and we look at the expansion of end systolic diameter to replace the valve. In other words, you can't wait until that end systolic diameter has grown enormously, because if it grows enormously, then you'll never be able to reverse it. So therefore, we are going to look to see whether the end systolic diameter goes above 55 millimeters for aortic regurg, 55 millimeters, 40 millimeters in mitral regurgitation. And remember, endocarditis prophylaxis is not indicated for any of these valve lesions. No longer for AR, MR, AS, MS, no longer for mitral valve prolapse or HOCM.
Mitral stenosis is most commonly caused by acute rheumatic fever. You got to look for an immigrant. Very little domestic rheumatic fever in the United States. Very uncommon because children get so many antibiotics. Now, it's a very low incidence of acute rheumatic fever, so therefore most of the time you're going to do a whole peds residency, never see one case. If the person is asymptomatic, you're not going to do any treatment. You're going to treat if they're symptomatic and don't do anything if they're asymptomatic, even if it's very narrow. So if you say to a person, hey, listen, you got an opening snap and a diastolic murmur, you'd be like, yeah, but I feel fine, so don't do anything. I feel fine, don't do anything. If you're short of breath, then you'll do something. But if you're asymptomatic, don't do anything.
One of the key features of mitral stenosis, allowing you to answer what is the most likely diagnosis, is to look for both a pregnant person or an immigrant person, and especially both. Now, step 2 of USMLE has to be able to give you significant clues. Therefore, if they don't give you the murmur, which shows an opening snap and a diastolic rumble, you look for that pregnancy, because in pregnancy there's a massive increase in plasma volume. This has to do with resetting the hypothalamic osmostat. In a normal person, you would shed off ADH at an osmolality of 280. But in a person who's pregnant, in order to increase the plasma volume, it continues to secrete ADH into the posterior pituitary. This 50% increase in plasma volume allows for the perfusion of the baby. In addition, for pregnancy, when you contract the uterus, it squeezes at least 500 milliliters extra into the central circulation. Most of our patients with mitral stenosis are immigrants to the United States, and immigrants for places where acute rheumatic fever is still common, it's still endemic, where people simply don't have the same level of access to antibiotics for pharyngitis.
Shortness of breath and congestive failure is simply the root base upon which all valvular heart disease occurs. But you're going to have to say they have shortness of breath and congestive failure and dysphagia as the left atrium presses backwards on the esophagus and it squeezes your esophagus and causes an obstruction to your swallowing. And you're also going to get hoarseness. You're going to get hoarseness as your left atrium passes on your recurrent laryngeal nerve and it causes hoarseness in time for your atrial fibrillation, because it has the largest left atrium, so therefore it has the largest amount of stasis and the largest amount of atrial fibrillation, therefore the largest amount of strokes. And hemoptysis, because that backflow of blood into your lungs bursts the blood vessels, and we are going to be looking for a young adult person who is 25 or 30 or 36 years old who had their rheumatic fever when they were 10 or 12, and now they're 36, and now you're like, oh man, why are you short of breath today? I don't know. Let me hear. Oh, click, click, click. Oh, I hear an opening snap. Are you hearing short of breath? Yes, I am. Are you having hoarseness and dysphagia? I don't know. Let me swallow. Oh, that sucked. Yep, you must have mitral stenosis. Ooh, if it isn't original artwork, and the enlarged left atrium in mitral stenosis presses on that esophagus, causing the dysphagia. And there's the arrow with it pressing backwards. The unique physical findings of mitral stenosis is very straightforward. 200 years ago, it was an opening snap after the S2, and followed by a diastolic rumbling murmur. 200 years ago, it was squatting and leg raise, making it worse. Squatting squeezes the leg veins. When you squeeze the leg veins, it increases venous return to the heart. When you lift the legs up in the air, it increases venous return to the heart. It's that forward. More blood in the heart leads to more murmur. More venous return, more murmur, period. And here's a diagram showing the opening snap, and that extra bulge to the right is showing the beginnings of the murmur when it occurs. As mitral stenosis worsens, does the opening snap happen earlier, or does the opening snap happen later as mitral stenosis worsens? As mitral stenosis worsens, the opening snap happens earlier because left atrial pressure creates the opening snap. And as mitral stenosis worsens, left atrial pressure goes up. Testing for mitral stenosis is not different than the testing that we've said at the beginning of the section in general. As it is for all valvular heart disease, the best initial test is a transthoracic echo, and TTE means transthoracic echo. Transesophageal echo is more accurate, and catheterization is simply the most accurate. Now, transesophageal echo is not always necessary, because if you can see what you need from the transthoracic, you don't have to do the transesophageal. But it's important to remember that a negative transthoracic doesn't exclude vegetations or small amounts of disease in the mitral valve. What is the most posterior structure in the heart? What is the most posterior? The most posterior structure in the heart is, well, it's the mitral valve. That's the most posterior structure. And the esophagus is posterior, and that's why the transesophageal echo has so much more accuracy, particularly for mitral stenosis. Right-sided lesions are anterior. The right side of the heart is the anterior surface. If you drew out the right side of the heart, 75% of the anterior surface of the heart is right ventricle. So therefore, in the right ventricle, the transthoracic and transesophageal for the right side is essentially equal. The EKG will show atrial arrhythmias, atrial fibrillation, atrial flutter, and left atrial hypertrophy, which is a biphasic P wave. Now, biphasic P waves occur because muscle drives the electricity. Electricity follows the muscle. So if the left atrium hypertrophies and the left atrium gets big, where's the left atrium? Posterior. Where's the leads? Anterior. So it pulls the electricity away from the lead, pulls the electricity away from the lead, and that's why the first part of the P wave goes forward to the right atrium, and the second part of the P wave goes backwards to the left atrium. Biphasic. Up, down, up, down. This EKG shows left atrial hypertrophy. If you look at these arrows in V1, you will see that they are pointing at a P wave that first has a positive deflection, then a negative deflection. So mitral stenosis results in a biphasic P wave, particularly in V1. V1 is an anterior lead. The first part is the right atrium, forward with the electricity, forward to the electricity. The second part is the left atrium, backwards. So it goes up, down, up, down. The chest x-ray is going to show left atrial hypertrophy. Well, that's easy to say. What does it mean? What do you actually see? You can't see the left atrium too well. It's not like on an EKG. See, on an EKG, it's normal to have a little bit of biphasic P wave. What's different is that it's a much bigger biphasic P wave in V1 and V2. A bigger one where the second part, the downward part, is bigger than the forward part. That's what's the main thing. It's not so much that it's a little biphasic, but big biphasic, where the second part is bigger than the first part on an EKG. And that's because when you look at the left atrial hypertrophy on the X-ray, you can see straightening of the left heart border. And the elevation of the left main stem bronchus, because you see, ooh, look at that. That left atrium will actually push it up. Left atrium will actually push it up, shoves it up because it's big. And that second bubble behind the heart is what's creating a big second part of the P wave in V1 and V2. The major issue is the second part of the biphasic P wave, the downward deflection, exceeds the size of the initial part in left atrial hypertrophy. The best initial therapy for valve diseases, it's diuretics and sodium restriction. And since we only care about people who are symptomatic, we're only looking at the people who have symptoms of fluid overload. Balloon valvuloplasty. If it's tight, let's get a balloon in it with a catheter. Remember, you can balloon with a catheter the mitrals, but you replace the aortics, and valve replacement for mitrals is the answer when a catheter procedure either can't be done or when it fails. Now, warfarin is not for everybody with mitral stenosis, but only when there's an atrial arrhythmia. Now, you may be looking, if you are a sophisticated student, for the newer anticoagulants, dabigatran, rivaroxaban. But dabigatran and rivaroxaban are specifically indicated for non-valvular atrial fibrillation. And this is valvular atrial fibrillation. In addition, we're going to control that rate with any one of these drugs. Now, ready? You must be prepared that if anything I say disagrees with what you previously have been taught, where somebody says, hey, you know what? I think that I was told by my attending, boom, we got to use verapamil. Well, you know what? That is simply local tribal customs. So when you get to something that disagrees with your previous attending, just go with what I'm saying, because this is not based on what's done in a particular state. This is a national, frankly international examination, and any one of these is accurate. You can answer what I tell you, and you can bet your career on it, and we will not let you down. The most common cause of aortic stenosis is a congenital bicuspid valve and calcification with age. Bicuspid valves are much more common than you might think. They really are. They are congenital, we don't know what happens, and then they calcify with age because what happens, the extra pressure damages the endothelial lining. The most common presentation of aortic stenosis, the most common presentation is angina. The most common wrong answer is syncope, because syncope is not the most common presentation. But I thought it was. You're wrong. The worst prognosis is congestive heart failure. You have a survival with congestive failure of aortic stenosis of about 2 years. You see, it's like cancer of the heart. It's about the same survival as metastatic cancer. You got to get in there and replace that valve before it dilates up. The murmur of mitral stenosis can be played for you on step 2. And you will have to know how to recognize it. Because we have isovolumetric contraction at the beginning, isovolumetric where no blood is moving, you don't hear anything at the beginning. That's why it's a crescendo, decrescendo. Because at the beginning, there's no blood moving, no murmur. It peaks in mid-systole. That's why it's diamond-shaped, or crescendo, decrescendo. And it's heard best in the second right intercostal space. Where does it radiate? Well, mitrals radiate to the axilla and aortics radiate to the carotids. And how it looks, here it is. It's a systolic murmur, crescendo, decrescendo, crescendo, decrescendo, and goes up to the carotids and heard best at the second right intercostals. I cannot overestimate how important the next slide is. The auscultatory maneuvers are critically and indispensably important. You are not to go into step 2 without you knowing that aortic stenosis and that valsalva and standing, which decrease venous return to the heart, will decrease the intensity of that murmur. Less venous return, less murmur. Hand grip. Hand grip, its effect upon the heart is to increase after load. Increase after load. An aortic stenosis softens murmur. Softens murmur. Make it hard for blood to get out of the heart. Softens murmur. Less blood ejected, less murmur. Hand grip does not increase venous return. Hand grip, you squeeze on something, and I compress the arteries of the arm, and it makes it hard for blood to get out. Increased afterload, less blood comes out, less murmur. Diagnostic tests for aortic stenosis. Transthoracic echo, then a transesophageal, then a cardiac catheterization is the most accurate test, and a chest x-ray will show left ventricular hypertrophy as the heart works it and gets thicker and thicker and thicker, and then you'll have a larger heart as it goes beyond 50% of the transthoracic diameter, and the EKG will show left ventricular hypertrophy, with the S in V1 and the R wave in V5 being greater than 35 millimeters. This is indispensable. Don't go into that test without knowing, and you're going to have to listen to some murmurs and know them for sure. Look, I wish there was medical therapy for aortic stenosis. I wish we had like aortic stenosis O dissolver, O binder, but there isn't. If you have shortness of breath from fluid overload, we can use some diuretics to try and decompress your lungs. But that's not going to treat your aortic stenosis. Not really. It's not getting rid of the aortic stenosis. Best initial therapy may be a diuretic, but the only truly effective therapy is to get rid of the valve. And even old people can tolerate, even 85 and 90-year-olds tolerate that aortic valve replacement fairly easily. Diuretics decrease the congestive failure, but they don't tolerate the volume depletion to get lightheaded. Balloon valvuloplasty is simply not routine for aortic stenosis. And you can't balloon calcification. You got to replace calcification. And you balloon aortic stenosis only if the person is too fragile or unstable to get the valve replaced. Mitral regurgitation is unbelievably common. First of all, etiology leading to an abnormal backward flow of blood through that valve. And so common to have hypertension dilating up the heart. You might say, well, I thought that causes hypertrophy. Well, it does at the beginning, and then it dilates up. Or endocarditis, making the valve leaky as it cooks that valve and burns through it, and then the valve just becomes leaky, which makes it dilate up some more. Now, papillary muscle rupture from myocardial infarction is a cause of acute mitral regurgitation. You acutely infarct, and the papillary muscle dies, and it's like the float in a parade getting loose by the ropes being cut. The most common cause is hypertension and infection and infarction and infection and infection and infection and infarction and infarction and infection. And anything that dilates up the heart leads to mitral regurgitation, because the leaflets don't actually change in size. So when the heart itself widens, those leaflets have to separate. You can't get the diagnostic question by simply saying, let's look for a person who's short of breath. All the valvular heart diseases make you short of breath. But the unique finding is, boom, 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 pansystolic murmur. Going to the axilla and obscuring S1 and 2. a pansystolic or holosystolic murmur. Remember, those words are interchangeable. They obscure S1 and 2 and it radiates to the axilla. And since hand grip increases, afterload. Hand grip increases, afterload. It pushes that blood backwards because regurgitant lesions are treated with afterload reduction. So there means increasing afterload makes it worse because the increasing afterload pushes the blood backwards. Hand grip worsens all regurgitant lesions because ACE inhibitors treat all regurgitant lesions. Squatting from a standing position squeezes the leg veins. Leg veins are big. Leg veins have big volume. Leg veins, when they're squeezed, put big volume in the heart and increase venous return to the heart. All left-sided lesions except mitral valve prolapse and HOCM are going to get bigger with expiration, and they're going to get bigger with leg raising and squatting because more blood, more murmur, less blood, less murmur, with everything except mitral valve prolapse and HOCM. Mitral regurgitation and the effect of those murmurs, squatting and leg raise, is super high yield. Knowing that they're all diagnosed with echo is important, but it's not as important as those auscultatory maneuvers. Let's take a look here at the bottom. This shows S1 and S2 being obscured. Remember, pansystolic or holosystolic means the same thing. Regurgitant lesions are treated with ACE inhibitors. Hand grip makes it worse. ARBs make it better. Hydralazine makes it better. Nifedipine makes it better. Vasodilators help. This is one of the most common questions for Step 2 CK. The best initial therapy for regurgitant lesions, even in the absence of symptoms, is vasodilator therapy. As you dilate the peripheral vasculature, it lowers the pressure in front of the heart. This makes it easier for blood to go forward. These are indispensable facts because they are frequently tested, because they are able to decrease the rate of progression of the disease. And digoxin and diuretics simply control symptoms, as they do for almost everything. They don't decrease the rate of progression, they simply control symptoms. Vasodilators make it decrease the rate of progression of disease. Stenotic lesions, when they're symptomatic, always need a mechanical fix. Regurgitant lesions don't. Regurgitant lesions can have their valve replaced simply when it dilates, even before you get symptoms. You can't wait for the end systolic. How empty it. How close did you get it? We replace the valve when the end systolic diameter goes above 40, or the ejection fraction drops down to less than 60%. Now you might say, I thought a 60% was a normal ejection fraction. It is, but not in a person who's got mitral regurgitation. In a person who's got mitral regurgitation, an ejection fraction of 57% is abnormal. Valve repair is an exciting new thing over the last couple of years. It means that instead of taking the whole valve out, you can put a clip or a suture, just tighten it up, tighten it up, tighten it up. It's like an episiotomy repair of your heart valve. Put in a couple of sutures and clips and tighten that thing up, and everybody's going to feel better. Our next valve lesion is aortic regurg. Now, the causes of aortic regurg are very similar to the mitral regurgitation, which is infarction or infection, anything that makes the heart or the aorta dilate, anything that kills off part of the heart makes the heart dilate, or hypertension where the heart eventually gets tired and starts to dilate. Infection, endocarditis has become a pretty rare disease, but if the valves are incompetent, they're going to regurgitate and dilate up the heart. Same as Marfan's or cystic medial necrosis or Ehlers-Danlos syndrome, or any of the things that might make the heart loose and floppy, make those leaflets loose and floppy, such as ankylosing spondylitis. Now, it's only 3 or 4%, and don't answer heart disease as the most common manifestation outside the axial spine of ankylosing spondylitis. The most common extra axial outside the spine manifestation of ankylosing spondylitis, the most common is the eye at 25, 30, 40%. But you get 3 or 4 good percent with ankylosing spondylitis. Now, Reiter's syndrome is also called reactive arthritis, and it's associated with aortic regurgitation as well. And of course, our old friend syphilis. Even though syphilitic aortitis may be uncommon, it's still important for you to know. There are several unique physical findings for aortic regurg that are indispensable for you to know. Besides congestive heart failure, the unique physical findings: wide pulse pressure, boom, 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 boom. The pulse pressure goes up because you know that a lot of the blood has to regurgitate backwards, so you can end up having a systolic of 150 and 160 and a diastolic of 50 or 60. That's huge. You can have a pulse pressure goes from the normal 40 to a pulse pressure of 60, 70, 80, 100, and that's felt as a water hammer pulse. Not that anybody knows what a water hammer is, but it's also sometimes known as a Corrigan's pulse. Boom, boom, boom. Quincke pulses, pulsations in the nail beds, you see them. Water hammer pulse, you feel. Quincke pulse, you see. Hill's sign is named after a guy named Hill. Not that the pressure goes down a hill. It's that the pressure inside the legs is above the arms. That's Hill's sign. Or whoosh, 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 moving your head up and down, and Demusset's sign. Memorize it. It's very easy for them to play audio recordings for you on step 2. It's a computerized exam, and you have to hear lub, psh, lub, psh, lub, psh, lub, psh. That's me acting out all the murmurs. Wait till I get to vowel sounds. It's heard best at the lower left sternal border because it travels down the root of the aorta, which goes like a cane curving around the thoracic aorta, goes curving down, and then the stick part of the cane goes down along the lower left sternal border. The hemodynamic effect upon the heart of Valsalva and standing. Valsalva, exhalation against a closed glottis. Ooh, like straining at stool. The Valsalva will decrease venous return, as will standing, because the venous capacitance vessels of the legs are opened up, so it makes that lesion smaller, softer, less intense, because less blood, less murmur. Less blood, less murmur for all left-sided heart lesions except mitral valve prolapse and HOCM. Hand grip worsens it because hand grip increases afterload, and increasing afterload makes this worse because you're treating it with an afterload reducer. So hand grip makes it worse because it increases the afterload. Here we have an S1 and a psh, an S1 and a psh along the lower left sternal border. The diagnostic tests for aortic regurgitation start out with EKGs and x-rays, which show left ventricular hypertrophy. But remember, left ventricular hypertrophy is not any more specific here than it is with aortic stenosis. So although they'll show the heart enlarging to the left side and the S in V1 and the R in V5 greater than 35 millimeters, it still is not enough to tell you it's aortic regurg. The treatment of aortic regurgitation, the best initial therapy is afterload reduction, as vasodilators make it easier for blood to leave the heart. if you are in the heart in the left ventricle and you have an easier time ejecting that blood, there is simply less force to dilate the heart abnormally, and the blood will go forward. This is not only going to improve symptoms, it will definitely delay the progression of the disease. And although digoxin and diuretics can be used with severely symptomatic patients, they don't decrease the degree of the disease, they don't delay the progression of the disease. They might be helpful somewhat to decrease symptoms, but that's it. Because we don't want to wait for the lesion to dilate the heart too pathologically, we are going to replace that lesion, or we're going to repair it. First of all, acutely with acute valve rupture, for sure, right away. But in chronic disease, if the ejection fraction reduces under 55%, or the end systolic diameter goes above 55 millimeters, you're going to replace the valve. Replace the valve at 55. Ejection fraction coming down. It's hard for people to understand, but I thought that 55 was still the lower limit of normal. It is, but if you're regurgitating, your ejection fraction be 60 and 70. That's why under 55 is bad. Replace the valve. Despite the fact that mitral valve prolapse is extremely common, it is essentially a normal anatomic variant in 2 to 5% of the population. That's why it's indispensable to understand that when you see a little prolapse, particularly in women, it is not to be treated unless there's symptoms. Marfan's and Ehlers-Danlos, which make all connective tissue loose and floppy, can definitely have mitral valve prolapse. But again, the key feature in mitral valve prolapse is, are there symptoms? And since most of them are asymptomatic, this is a really important source of questions, where it says a person has syncope or some other reason to get an echo. And they have this problem or some other problem. They get an echo and they say, it reports mitral valve prolapse. You say to the patient, hey, are you having any atypical chest pain? And they go, no. Are you having any chest pain? No. Are you having any palpitations? No. They say, well, are you having any anxiety? Well, even if there was just anxiety, you're not going to do anything about the heart valve just for anxiety. You treat it if there's pain or palpitations, atypical chest pain or palpitations. And it's hard for people to understand. Hey, listen, there's valve regurgitation. How come you're not symptomatic for congestive failure? It's a matter of degree. The amount of regurgitation is not enough to result in shortness of breath, and that's why you don't have to treat it. Now, what's unique about the murmur of mitral valve prolapse? Well, there's a couple things. One, a mid-systolic click is quite unique, and that mid-systolic click is followed by a murmur, click-murmur syndrome, click-murmur syndrome. And the murmur is the murmur of mitral regurgitation. Now, let's get to the unique features. Mitral valve prolapse gets worse when the heart is smaller, because the smaller the heart is, the worsening the prolapsing valve, because the valve, prolapse means your valve is simply too big and floppy for the size of your heart. It's like a size small heart wearing an extra large valve, and it goes floppy, floppy, floppy. So anything that makes the heart smaller, such as Valsalva, decreases venous return to the heart, or standing decreases venous return to the heart, will worsen the murmur of mitral valve prolapse. And anything that increases the size of the heart, anything that increases venous return, anything that prevents the heart from emptying, increased return, decreased emptying, will make it better. Increased return, squatting. Decreased emptying, hand grip, makes it better. Well, here's a picture of the extra loose floppy valve bellowing backward, billowing into the left atrium as the heart contracts. It's going up like a parachute there, and that explains a lot. When it comes to a stop, that's when you get the click. And if it doesn't seal, if it doesn't fit, that's when you get the murmur. The diagnostic tests of mitral valve prolapse are not different from the others. Echo is the best initial test. Catheterization is the most accurate test. But catheterization is almost never done on a lesion that you virtually never replace. You don't even treat most mitral valve prolapse. It's mostly an asymptomatic finding on an echo done for another reason. Don't even treat it asymptomatic echo done for another reason. Asymptomatic echo done for another reason. You would treat it if somebody had severe symptoms, beta blockers first, and you replace it only very rarely. Most mitral valve prolapse doesn't need treatment. It's very simple. No symptoms, no treatment. Click, no symptoms, no treatment. Click murmur, no symptoms, no treatment. Abnormal echo, no symptoms, no treatment. Oh, pain, palpitations. The best initial therapy is beta blockers, but only when there's symptoms. Valve repair is almost never needed. Valve repair with a catheter to clip or tighten those valves, to stitch them together, tighten the leaflets. The surgical repair is rare, rare, rare. But endocarditis prophylaxis is never. You're having all your teeth removed? You don't need prophylaxis. You're having bloody procedures? You don't need prophylaxis. Not even if there's a click? No, not even if there's a click. Not even if there's a click and a murmur? Not even if there's a click and a murmur. The answer for endocarditis prophylaxis from mitral valve prolapse, no matter what procedure you're doing, is always no.